what are the clinical symptoms of these patients. Now, if a patient is having long-standing otalgia, this otalgia can be severe otalgia and otorrhea. So patient will tell you, I am having this pain since 1 week, doctor, 10 days, doctor. It's not alarming. They won't come to you on day 1 or day 2. They'll come to you with a delayed presentation. They'll think that it's okay, it will come down, it is mild pain. Only when it becomes unbearable pain, when it has passed through the cellulitic phase and the perichondritic phase, and when it has caused an osteitis, and now there is actually osteomyelitis of the bone causing excruciating pain, that is the time they're going to present to you. They will tell you there is ear pain that increases with the movement of jaw, that is increasing with chewing certain food. So that is the primary manifestation. So these patients have otalgia as the primary manifestation or the primary symptom. Pain is often the initial presentation, and it is severe throbbing pain, and this is worse at night because of osteomyelitis, and when they have come to you already there is osteomyelitis, so they have severe throbbing pain, and this pain is extremely worse during the nights. There can be discharge coming of the external auditory canal that is scanty and foul smelling in nature. And when this discharge is foul smelling, it indicates there is the presence of osteomyelitis. It indicates now that there is bony involvement, and bony involvement will tell us it's a bad prognosis. So you know that what you have to give to the patients, how much can you tell them about the possibility of recovery, how much guarded should you be in your judgment. So presence of foul smelling discharge tells to you that there is osteomyelitis. Ironically, the patient does not have fever or constitutional symptoms. See, we know aggressive organism is Pseudomonas. It is a bacterial infection. So don't we expect to have fever, constitutional symptoms like headache, lymphadenopathy, myalgia, toxic features? We expect. But do we have that? No. This is ironical. That is why the patient do not present to you as an early symptom. They will have ear pain. They'll think it's a simple ear pain. They might take some ototopical medications from the nearby pharmacist, and they might not actually come to you. They'll be given some antibiotic drug and some analgesic drug, and they might feel better for 2 to 3 days. They might be okay for 4-5 days, and they do not see you. When the disease has actually gone to the bone is when they have excruciating pain, foul smelling discharge, worsening pain at night that is throbbing in nature. That is when they think of seeing a doctor, and that is when there is already involvement of the bone, making us think that yes, this is definitely a poor prognosis. But when we say about poor prognosis, does it mean that we do not take an active interest in the patient's treatment? No, we have to definitely take an interest. Whether the prognosis is good or bad, that is only for your understanding and counseling of the patient. But whatever it is, even if there is a poor prognosis, we as clinicians must make sure that we're giving 100% when it comes to the treatment aspect of the patient. And even if there is a worse prognosis, there is always a bleak of hope. There is a leap of faith that you take and think that yes, my treatment can help the patient, my intervention can help my patient, and whatever is the best possible treatment for the patient at that stage of disease can sometimes also help in recovery of the patient. Not every patient with malignant otitis externa will die, but yes, if you are aggressive in your treatment, if you have done a timely therapy, if you have been able to establish a good clean cavity with your debridement, then yes, the possibility of recovery is much higher. So now that you know the basic symptoms, there is a categorization of symptoms that we have today by Cohen and Friedman. They say that there is some obligatory symptoms and there are non-obligatory findings that you must have in the diagnosis of malignant otitis externa. So what is this criteria? Let us understand. So this criteria was given by Cohen and Friedman. So what does this criteria say? There are two things in the criteria. The first thing is obligatory or major criteria, which is definitely going to be your obligatory one, which must be there to help you to the diagnosis. The second one is going to be your minor criteria, which is definitely occasionally you might have these symptoms. So what is the major or the obligatory criteria? The first thing is pain. Pain, I told you, is a very important feature. Severe throbbing pain that is worsening in night is something that you must look for. Number two, if there is edema of the external auditory canal, if you see exudate in the external auditory canal, if you see granulation in the bony cartilaginous junction, That will help you get to the diagnosis. Now, if there are micro abscesses, now micro abscesses you won't know on examination. How will you know micro abscesses? Micro abscesses are understood only on surgery. So, if you have operated and on surgery you have seen micro abscesses in the area where there is infection, again that is something that is a major criteria. So, if there is a positive micro abscess, or if there is a positive technetium 99 scan, or if you have got focal neurological deficits. If there is neurological involvement like this seventh nerve involvement, and last but not the least, the patient has taken treatment and not responding to the treatment for more than 1 week. So, failure of local treatment, meaning local antibiotics, topical drugs. So, local treatment failure for more than 1 week is something that we see in major or obligatory criteria for malignant otitis externa. Now, what's there in the minor criteria? Minor criteria is diabetes. Number 2, cranial nerve involvement. Number 3, if there is a positive radiological changes that you see. Number 4, if there is any debilitating conditions associated with the patient. And number 5, if it is a older age. So, neurological is not under the major, it is basically under the minor criteria. So, these are criteria that you must look for whenever we are thinking about malignant otitis externa. This was guided by Cohen and Friedman, and major obligatory are pain, edema, exudate, granulation tissue, microabscesses, positive technetium scan, and failure of local treatment. Minor criteria is diabetes or involvement of the cranial nerves, radiological scan which is positive, and diabetes or older age. These are minor criteria which are occasionally we see. Now, what is the hallmark? I have already told to you the hallmark of malignant otitis externa. The hallmark of malignant otitis externa is the presence of granulation tissue. So, can you see here, there is a granulation tissue at the bony cartilaginous junction. So, if you have got granulation tissue at the bony cartilaginous junction, it is highly possible that the patient has malignant otitis externa.